Welcome back to Emergency Insights. I'm your host, James Carter. Today, we're diving into a critical topic for any clinician working with pediatric populations, the latest AHA guidelines on pediatric hypertension. This is a domain that's seen evolving definitions and a renewed emphasis on early, accurate detection. As healthcare providers, our understanding of these updates is key to improving long-term cardiovascular outcomes in our youngest patients. Let's begin with definitions and classification. For children under the age of 13, hypertension is defined as a blood pressure at or above the 95th percentile for age, sex, and height, and this must be confirmed on multiple occasions. For adolescents aged 13 and older, the AHA aligns the definition with adult criteria, meaning a blood pressure of 130/80 millimeters of mercury or higher now qualifies as hypertensive. Also worth noting, the terminology has changed. What was previously referred to as prehypertension is now called elevated blood pressure. This is a subtle but important shift that better reflects the associated cardiovascular risk. Routine screening plays a vital role in early identification. Blood pressure should be checked during preventive health visits starting at age 3. For children with known risk factors such as obesity, chronic kidney disease, or a family history of hypertension, the frequency of monitoring should increase accordingly. Measurement accuracy cannot be overstated. Proper technique includes ensuring the child is seated calmly with their back supported and arm positioned at heart level. Multiple readings should be taken and averaged. As with adults, improperly sized cuffs and rushed measurements can lead to misclassification and inappropriate management. For diagnosis, the AHA emphasizes that elevated readings must be documented across at least 3 separate visits. Ambulatory blood pressure monitoring is strongly recommended to confirm the diagnosis. This tool is especially valuable for identifying white coat hypertension, where readings are elevated only in the clinical setting, and masked hypertension, which may go unnoticed during standard office visits. When it comes to management, the first line of treatment is lifestyle modification. This includes implementing a healthy diet, one that closely mirrors the DASH diet, and encouraging physical activity for 30 to 60 minutes on most days of the week. These changes not only lower blood pressure, but also contribute to overall metabolic health. Pharmacologic treatment should be considered if lifestyle interventions fail to control blood pressure or if there are signs of more severe hypertension, particularly when end organ effects are evident. One critical point: before initiating antihypertensive medications, an echocardiogram is advised to assess for potential cardiac changes, such as left ventricular hypertrophy. Children with chronic kidney disease present a special consideration. They typically require stricter blood pressure control and more intensive monitoring due to the strong association between hypertension and CKD progression. To summarize, the AHA guidelines reinforce a few central themes: early identification, precise measurement, and a thoughtful stepwise approach to treatment. As clinicians, our role is to translate these guidelines into action, promoting cardiovascular health from the earliest stages of life. That wraps up today's episode of Emergency Insights. I'm James Carter. Stay informed, stay precise, and as always, stay prepared.